This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
She is a 65-year-old lady who has Phacomorphic glaucoma. She presented to the outpatient with a pressure of around mid-40s, and she was treated with anti-glaucoma medications and topical steroids. 3 days later, the pressure is under control and she's posted for surgery. Now, looking at the morphology of the eye, the antechamber is extremely shallow, and this is the antersegment OCT picture confirming the same. And these are the slit lamp pictures. You can see that the antecapsule is literally bowing out anteriorly, and there is a higher chance of the rhexis running away. Now, these are the biometry readings. The axial length is 21.7 millimeters and the antechamber depth is 1.67. So we are dealing with a short eye and it is vulnerable for angle closure. Along with it, now because of the intumescent lens, we've got an extremely shallow chamber. This patient is put on IV mannitol before surgery, and also I'm doing the surgery under peribulbar block and massage so that the eye becomes soft as before I enter the eye. While making the side port incisions, I need to be mindful that the side port blade might have a risk of puncturing the antercapsule because the capsule is tented up and the antechamber is very shallow. So I'm very cautious about it as I'm doing the side port incisions. The antercapsule is stained with trypan blue under the air bubble. Having a good stain of the antercapsule is critical in such eyes. The chamber is filled with a dispersive OVD. I'm using a combination of sodium hyaluronate and chondroitin sulfate. This ensures better chamber stability as I'm doing the rhexis. The main 2.8mm incision is created. Now time to perform the most critical step of the surgery, the rhexis. And let's see how things are done. Looking at this situation, I've decided that I'm going to perform a two-stage rhexis. The first rhexis is going to be around 3mm, followed by decompression of the bag and then a secondary larger rhexis. So I want you to focus on the way the rhexis is done. I create a small puncture and you can see the amount of tear which I have got is much more than what I had expected. The tear is already hinting to run away. So quickly I grab the flap, and the most important thing is not to fold the capsule as we typically do. What I'm doing here is the tearing technique wherein the capsule is not folded, it is just held flat and then the tearing is begun. After a short lap, I re-grasp the antercapsular flap, and again without folding the capsule, the tearing is done in a circular fashion. So contrary to the classical shearing technique which we do wherein the capsule is folded, here I am using the tearing technique to perform the rhexis. Again, after a short lap, the flap is re-grasped and the final stretch of the rhexis is done. So now we have a very small rhexis which is about 3.5mm. It's not circular, it's slightly heart-shaped. Nevertheless, having a continuous small rhexis is critical, and now is the time to decompress the bag. So the contents of the bag are relatively thick, unlike soft fluid matter. So I'm going to use the Phaco probe itself to decompress. So the settings are in the epinucleus mode. We've got high vacuum and high flow rate and a very low Phaco power. The idea of using the Phaco tip is the wider bore of the Phaco tip is much more efficient in quickly debulking the capsular bag of the thick swollen cortex and the epinucleus rather than using the smaller bore of the irrigation aspiration device, which has got an opening of just 0.3mm. The second instrument is used to rotate the nucleus so that the equatorial swollen cortex is also pushed anteriorly, and a thorough debulking of the capsular bag, including from the equatorial regions, is done. Once I'm confident of the decompression of the capsular bag, I come out. The chamber is refilled with OVD. Again, care is taken to place the OVD in the peripheral part of the antechamber, not in the central opening of the antercapsule. A tangential cut is given to the antercapsule using a micro scissors. The flap is held by the forceps, and then the secondary larger rhexis is now being done. Now you can just observe that we have got such great control now compared to the primary rhexis, simply because the bag is totally decompressed. There's no positive pressure which is pushing us. So I have a nice 5 millimeter opening in the anterior capsule, and the most critical step of the surgery is done. Time to deal with the nucleus. The nucleus is relatively soft and it's not going to be a difficult task to manage this. The tip is buried into the substance of the nucleus. The sharp vertical chopper goes down and then lateral separation is done. Now we have the first chop. The nucleus is rotated. The tip is again buried. The second vertical chop is done and the fragment is divided. The same process of vertical chopping is continued into the second heminucleus as well. So now we have multiple small fragments. Now is the time to emulsify each of them. The settings are changed to the quadrant removal mode, and I'm going to use only the torsional energy with a high flow rate and vacuum. And each of these fragments is then emulsified in a very controlled manner. Last 3 fragments are remaining. Time to refill the chamber with some OVD and eventually all the fragments are emulsified. Cortex aspiration is done, and I felt the zonules were healthy, and these weak zonules were itself responsible for the forward movement of the lens iris diaphragm, resulting in a secondary angle closure. That's the reason why I would like to support this bag with a CTR. So CTR, which is 10 to 12 millimeter. The CTR is being placed into the capsule bag and followed by the intraocular lens implantation. Time to remove the OVD both in front and behind the lens. The irrigation cannula is slid under the intraocular lens to wash away all the OVD which is sticking onto the posterior surface of the lens and within the bag. Now the OVD which is in front of the lens is aspirated out. Time to close. Hydration of the 2 side port incisions are done, as well as the main incision. That's it. Case is done. Now these are the first day post-op pictures. The patient continues to do well. The pressures are under control. She has an excellent visual recovery and she's happy. I had mentioned in a couple of my previous videos that I've started performing a 2-stage rhexis. This is one rare instance where the anterior capsule was really protruding forward and the risk of the rhexis running away was extremely high. Now look at these cortex fiber which are there. They're extremely swollen and jelly-like. There is no pocket of liquid which is there. And these are the cases where the chances of the rhexis runoff is very high, and maybe these cases deserve a little bit of a special attention. So operating on a soft eye, like I used IV mannitol and giving a block and massage, softens the eye significantly and made the job of doing the rhexis very easy. However, one important modification which I did here was, rather than using the classical sharing technique, I used the tearing technique here, wherein the capsule is not folded but rather it is held flat, and then in a controlled manner the tearing is done. So once the decompression is done, the secondary rhexis is a cakewalk. So that was it. Thank you for watching and hope you found this helpful.